Hello and good evening. Welcome to another edition of OrthoCarolina's monthly webinar series. My name is Dr. Fletcher, and I'll be talking about ankle arthritis. As a reminder, this will be live streamed on our Facebook, LinkedIn, and YouTube platforms. And please do not hesitate to ask questions throughout the presentation, and I will try to address them all at the end. So first, a little bit about me. I am from Missouri originally, kind of small town outside of St. Louis, Missouri. Did my undergrad in medical school at the University of Missouri, Kansas City. I was part of their 6-year combined BA and MD program. So did both my undergrad and medical school within this 6-year program, which was really exciting. And then I went to graduate school at Kansas University, where I got my Master's of Science in Clinical Research. I then came out to North Carolina to do my orthopedic surgery residency at Duke. And then I went to Baltimore for a year to do an extra year of fellowship training just in foot and ankle surgery. And then I was fortunate enough to join the OrthoCarolina team, and I've been with them for about 2 years now. So this evening, we'll talk about the diagnosis of ankle arthritis, risk factors, management, including both surgical and non-operative options, and then outcomes. So we'll begin by just talking about what is arthritis. So the root word arthur means joint or articulation, and itis is our medical suffix for inflammation or disease. So really arthritis just means inflammation within a joint. And this can cause symptoms such as pain, swelling, and stiffness. Now, it's important to know that arthritis is a huge mixed bag. So there's over 100 types of different arthritises. Osteoarthritis is the most common we typically hear of, which just happens with age. But there's also a lot of inflammatory arthritises like rheumatoid arthritis, gout, psoriatic arthritis that you see in sometimes younger patients. Septic arthritis happens when there's infection in the joint, and that's typically a surgical emergency. So again, all different types. And this is what a normal joint looks like. This is a knee, but with arthritis, you get these inflammatory cells in the joint, and it can happen just the setting of overuse. So you might just get a painful and swollen joint, and all of those inflammatory cells are really toxic to the cartilage, and the cartilage is the cushioning inside the joint. So over time, you'll start to see cartilage destruction and cartilage loss, which causes joint space narrowing, and then you'll get these bone spurs. You can also start seeing cyst within the bone. The bone can turn really hard and sclerotic because now you can start rubbing bone on bone. So that's all sequela that we can see on X-ray or other imaging that indicates to us the patients have arthritis. Now, ankle arthritis is a little different than other joints in that most commonly it's due to post-traumatic arthritis, 70 to 80% of the time. And that means you've developed arthritis following an ankle fracture or sprains. And that's different than the knee and the hip, where the majority of arthritis is osteoarthritis. However, in the ankle, that only accounts for about 10% of arthritis, and then inflammatory arthritis kind of makes up for that last 10%. There's also a lot of challenges when it comes to arthritis in the ankle. So we typically see this in younger patients than the hip and knee. So patients in their 30s and 40s will present to us with ankle arthritis versus older patients around 50 to 60 that will present with knee and hip arthritis. This is also a 3-bone system, and we'll go over the anatomy, but the tibia, the fibula, and the talus are the 3 bones that make up the ankle joint. The ankle joint itself has thinner cartilage or cushioning inside the ankle. There's a smaller surface area, and more weight is transferred through the ankle. So I always remind my patients that when we walk, up to 5 times our body weight actually goes through our ankle, and when we run, up to 13 times our body weight. So we'll just start with some basic anatomy of the ankle. So the tibia is the shin bone, and that forms the medial malleolus, which is the ball kind of on the medial or inside of the ankle joint. The fibula is the smaller bone on the outside of the ankle, and that forms the lateral malleolus, or that lateral ball on the outside of the ankle. The talus is the block-shaped bone that sits underneath, and then that articulation of those 3 bones forms the ankle joint. So in the X-ray on the right, you can see that green space. That's actually the ankle joint itself. Now, the cartilage lives inside there, and we just can't see cartilage on X-rays. So symptoms of arthritis in the ankle, similar to other joints, is pain, swelling, stiffness, mechanical symptoms. So you might start to feel like catching, clicking in the ankle, and then difficulty walking. So on diagnosis, we always start with the history. So talking to our patients to decide or to hear their story about their pain, swelling, stiffness, mechanical symptoms. And then on physical exam, there's a lot of different findings of ankle arthritis. So you typically will have tenderness at the ankle joint, decreased motion. You may have a lot of swelling or like an effusion in the ankle, palpable bone spurs, deformity, or even ligament instability. And then on x-rays, for studies, we always start with basic x-rays, but oftentimes we may need more advanced imaging like an MRI or a CT scan to really help us see the degree of deformity or arthritis in the ankle. Now, these are clinical photographs of a patient who has end-stage ankle arthritis, and what can happen over time is you can start to get deformity in the ankle. So this patient's right side is fairly normal versus that left side, you can see that ankle is starting to collapse. And this is a normal ankle x-ray. So again, the joint surface is nice, smooth, and congruent. There's good joint space there. The black is the joint space, and that's where the cartilage lives. And that's in comparison to these x-rays. And so the x-rays on the left are a patient that has both of these patients have post-traumatic arthritis. The patient on the left had an ankle fracture and has collapsed that joint space over time, but the alignment is actually well maintained. There's just no joint space left. The patient on the right, these are x-rays we typically see after patients have had a history of really bad ankle instability and frequently rolling your ankle. And that can cause this deformity where the ankle kind of starts to collapse inward like that. We see a lot of big bone spurs around the joint. So these are both examples of end-stage post-traumatic arthritis. Certain risk factors, again, are age. Most commonly, osteoarthritis is the arthritis that happens in older patients that we see more commonly as you get older. Prior ankle trauma, so again, ankle fractures, ankle sprains, ankle instability, autoimmune or inflammatory conditions. Again, that includes our gout, rheumatoid arthritis, obesity, and then there's a family history, so a genetic component as well. We always begin with non-operative management for patients. So I'm sure we've all heard of RICE therapy, and that just consists of rest, ice, compression, and elevation. A lot of that can help mitigate the swelling and pain. And then there's medications such as steroids or non-steroidal anti-inflammatories. Orthotics, and these are just shoe inserts that go in your shoe that can sometimes help correct some ankle alignment. There's custom orthotics that are custom made for your foot. Bracing, and there's standard over-the-counter braces, but then there's also a lot of new technology when it comes to custom bracing options. Physical therapy can really help maintain some of the motion in the ankle and also strengthen the muscles and ligaments surrounding the ankle. Injections, including steroids and PRP injections. Now, a steroid injection in the ankle is something we can do in the office. We can perform it same day. Typically, you should expect temporary relief, and it's more effective in patients that have more mild arthritis. Once you have advanced arthritis and you've really lost that joint space, these definitely become less beneficial. And typically, we don't like to perform these more than spaced out more than every 3 months. And moving on to surgical treatment. So it's important to know that one size does not fit all. So we approach every patient individually. There's a lot of factors that go into us deciding what's the best surgical option for you. How long have your symptoms been present? Age, medical comorbidities, the soft tissue envelope, and that's really important in patients that have had prior trauma. Deformity, bone stock and quality, again, important in maybe patients that are older and that have osteoporosis. And then the health of the surrounding joints. So here are different surgical treatment options. There's many, many more than this, but we're going to focus on a few here: ankle arthroscopy, ligament reconstruction, ankle fusion, and ankle replacement. So ankle arthroscopy, that means an ankle scope, and that's both diagnostic and therapeutic. Meaning diagnostic, we put the camera in, we can see the health of the cartilage of the ankle. It gives us a lot more information than just the exam or imaging alone. And then therapeutic, because we're able to put certain instruments in and can help clean out scar tissue, address some cartilage lesions or bone spurs. And so indications for an ankle scope may be ankle impingement. So some patients will get soft tissue, like scar tissue in the ankle, that causes painful impingement symptoms. Bone spurs can also cause bony impingement. Patients that, again, have early arthritis, loose bodies in the ankle. So sometimes you can knock off pieces of bone or cartilage, and that can cause loose bodies that get caught in the ankle and cause those mechanical symptoms. It can be quite painful. So those can be removed through the ankle scope. Patients with ankle instability or ligament injury, and then osteochondral lesions, which I have an example of that here. So osteo means bone, chondral means cartilage. And so these are lesions that involve both the cartilage cushioning in the ankle joint and the underlying bone. And this is what an ankle scope looks like. So looking into the ankle, you can see on the left side here, on the bottom right, that is normal cartilage. So there's all three bones there in the ankle that make up the ankle articulation, and the cartilage is this smooth, healthy porcelain appearing material. And then the picture on the bottom right, that's a patient that had a big osteochondral lesion. So it looks like a pothole in the ankle joint that affects both the cartilage and underlying bone. So that's something that we can address with an ankle scope. And then ankle ligament reconstruction. This is considered in patients that have recurrent ankle instability. So most commonly when patients roll their ankle, they'll have an inversion injury, which is the picture on the top where you roll your ankle in. And there's a few ligaments on the outside of the ankle that are most commonly injured. And over time, if you have repetitive ankle sprains, those ligaments can become really loose, and that causes you to continue rolling your ankle, and that can be really harmful to the ankle joint itself, to the health of the ankle joint. You can start developing scar tissue, bone spurs, and this all causes those kind of ankle impingement symptoms, and you'll develop pain. About 30% of patients who have ankle instability will have those big, sometimes smaller, larger osteochondral lesions. So every time you roll your ankle, you risk dinging that cartilage inside the ankle and causing early arthritis. The bottom right are pictures of what this surgery looks like. So typically we'll start with an ankle scope where we put the camera in, clean out any scar tissue inside the ankle, and then you'll have a small incision on the outside of the ankle where we'll tighten up and repair those ligaments. Typically it's performed with a couple anchors that go into the bone where we're then able to imbricate or pull up and tighten those ligaments. Now moving on to ankle fusion, or arthrodesis is another term for fusion. This is performed in the setting of end-stage ankle arthritis. This may be in patients with comorbidities that preclude them from having an ankle replacement, and also in younger patients. So younger patients that are too young, it's too early for them to get an ankle replacement because they'll wear it out too quickly and have some major complications, we may consider an ankle fusion in. And goals for that are to relieve pain, correct deformity, and improve their function. Now, this is both a joint and motion sacrificing surgery, meaning the ankle joint will never move again. However, there's excellent compensatory motion from the surrounding joints. So here's a video of a patient that actually has an ankle fusion, and you can see how much motion they actually still have in the foot. And that's coming from the hindfoot joints, the midfoot joints, which are all the joints that surround that ankle. But the ankle itself is actually not moving at all here. And I perform a lot of minimally invasive surgery. So this is something that in the right patient, it can be performed minimally invasive. And so that's done through a couple of poke holes, and typically with an ankle scope, where we'll be able to clean out the ankle joint, remove any remaining cartilage, and then get that bone prepared to fuse or to weld together. And then the screws are placed by a couple little poke hole incisions as well. So this is a patient example of that had an ankle fusion. And then this is a graph just kind of showing how the paradigm has really swung away from ankle fusions and towards ankle replacement. And so this is looking at over the last 20 years, or dating back to 2007. But you can see on the top in the orange is ankle fusion. So used to be the most common surgery performed for end-stage ankle arthritis. And now, starting about 10 years ago, and around 2011, 2012, that paradigm really swung, and now ankle replacements are much more common than ankle fusions. So ankle replacement, this is not a new concept. We replace a lot of different joints, knee joint, hip joint, most commonly shoulder. But I have a lot of patients that are actually surprised to hear that we do perform ankle replacements, and they are a great surgery in the right patient. And this is something I love talking about just because I've done a lot of research in the field. So here's all some of my previous publications of ankle replacements, and our OrthoCarolina team here continues to study our patients and to advance the field, particularly when it comes to ankle replacements. So that's been really exciting to be part of the team. And this is what an ankle replacement looks like. So similar to other joints, there's typically two metal components, either cobalt chrome or titanium, and then there's a piece of plastic in between that acts as the cushioning between the joint. And so you're able to get that ankle motion by that kind of plastic articulating with the metal. Now, the goals of ankle replacement, similar to fusion, is to relieve pain, correct deformity, but the difference here is now we're preserving the motion at the ankle joint, and then ultimately improving your function. Now, ankle replacements are performed in older patients. We really like to wait until you're at least 50 or older, just so you don't wear it out too quickly. And there's been a lot of continued advancements in materials and design that have led to a lot of exciting changes in ankle replacements, and that includes patient-specific instrumentation, which is becoming much more common. And I have a slide to show you guys that. But with all of these advancements that we have now, ankle replacements do really well. So the 10-year survivorship is over 90 to 95%. So after an ankle replacement, 10 years down the road, about 95% of those patients still have their ankle replacement, are doing really well, and are really happy. Now, this is an example of that patient-specific instrumentation. So before surgery, we'll get a weight-bearing CT scan. And what that means is you get a CT scan as you're standing, and that helps us assess your alignment. And our OrthoCarolina team has one of the only weight-bearing CT scanners in the area, and that just gives us a lot of information before surgery. So we actually scan your leg from the knee down to the ankle, and then we send that information to the implant teams who have different engineers, biomedical engineers, that help us make these custom guides that are specific for your ankle. Now, these are used in surgery for us to help guide where the bone cuts are made, the different implant sizes that will fit you best, so that we're able to give you the best outcome. Now, this is a patient example of mine. This patient had a history of recurrent ankle instability, so frequent ankle sprains. You can see again on this x-ray, his ankle was really turning inward. So he had a lot of deformity at that ankle as well. Big bone spurs on the inside and outside. And then the x-rays below or after we replaced the ankle. And he is only about a month out from surgery in those x-rays. And I'm just going to briefly review the post-operative course here, but it's important to note that the specific post-operative course is very surgeon-specific, so we all have a little bit of our own preferences, and then also patient-specific. So we always alter this depending on how the patient's doing. But just kind of typically broad terms, for the first 4 weeks, you're not able to put any weight on the ankle, and that's primarily because the soft tissue envelope in the front of the ankle where we make the incision is really tenuous. So that period of immobilization and no weight is really just for soft tissue rest to allow that incision to heal. I like to see my patients back about 1 week after surgery to get the splint off, put a new clean dressing on with a cast. And then I'll see you back at 3 weeks after surgery. We'll get the stitches out at that point. And if the incision's healing well, hopefully we can get you into a boot. And that allows you to remove the boot and start some ankle motion exercises. Now, anywhere between 4 to 6 weeks after surgery, we'll have you initiate physical therapy and start gradually putting some weight on that new ankle while you're in the boot. I'll see you back at 6 weeks. And then depending, again, how you're doing, anywhere from 6 to 8 weeks, we'll have you start transitioning out of the boot into a sneaker with or without an ankle brace. And then we'll continue following you closely at 3 months, 6 months, and at a year. And then we have a great relationship after that. And I keep seeing you annually for the rest of you and your ankle's life. But I always tell patients to anticipate gradual, continued improvement for up to 1 year after these surgeries. Now, this is another patient example, and
Yes. All right, yeah, show us that.
I'll try to turn that down. So she was actually at this visit only 6 weeks following her ankle replacement. So you can see how much motion she has at that ankle joint. I'll play this one again. So great motion. And then she also showed me this picture of her already horseback riding at 6 weeks, which was not allowed. It's a little too early, but was just a testament for how well she was doing and how she was feeling at that 6-week time point. So some final thoughts on ankle arthritis. There's multiple different types of ankle arthritis, and it's really a continuum of a disease process. So there's early arthritis, which we might not even be able to see on x-ray. It's just some inflammation or swelling in the joint, all the way to end-stage arthritis. Both conservative and surgical management options can be helpful. And then the treatment is very patient-specific. So based on you as an individual, age, activity level, comorbidities, symptoms, and then the degree or severity of your arthritis. So I want to thank everyone for attending this evening, and I am going to open the floor to questions, and I'll try to answer as many as I can. All right, just give us one moment here and we will get those questions going for us. All right, so first question here, sorry about the pause there. First question here, what are some symptoms of ankle arthritis to look for to determine if a higher level of treatment may be necessary? So if it's really a pain and a function question. So if at any point your pain is starting to inhibit your function or your desired daily activities, that's certainly when it's time to seek treatment. But one of the things we talked about was ankle instability. So if you're having recurrent ankle instability where you're really rolling and spraining that ankle commonly, certainly please come see us. Physical therapy to start strengthening is really helpful, but you may need surgery because oftentimes that instability rolling the ankle might not always be painful, but it does cause a lot of damage to the ankle joint itself. And then any mechanical symptoms, locking, clicking, catching, that may be an indicator of like a loose body in the ankle, a loose flap of cartilage that may require surgery to be removed. How does orthopedic research impact your practice with ankle arthritis? So we do here at OrthoCarolina, especially the foot and ankle team, we do a lot of research on ankle arthritis, ankle replacements. So it has a really powerful impact on our practice because one of the most exciting things about foot and ankle is it's a newer field within orthopedics and a lot of things are changing. So 20 years ago, kind of like we talked about, ankle fusions were so much more common and now ankle replacements are much more common. And that's all due to orthopedic research, design, people continuing to follow patients and make sure that patients are doing well and we're doing the correct thing for them. So one specific patient here asks, I had a peroneal tendon repair, tightrope procedure for an unstable ankle and other items. I was told I now have subtalar arthritis. What is your opinion to deal with pain and discomfort? So the subtalar joint is the joint that sits below the ankle. It's one of our hindfoot joints. So this patient had ankle instability. And then peroneal tendon repair. The peroneal tendons can also get damaged with recurrent ankle instability. So it sounds like this patient, you had your ankle tightened with the ligament procedure and the peroneal tendons repaired. But the arthritis that you've developed in the subtalar joint below the ankle, that is also a joint that we can treat kind of in similar measures with starting conservatively, bracing, injections, anti-inflammatories. That joint is the joint that allows you to tip your ankle or your hindfoot side to side. So a lot of that inversion, eversion, which is the side to side tipping, comes from the subtalar joint. So injections, bracing, all these conservative things may be helpful, but if the subtalar joint becomes too arthritic, that's actually a joint that we fuse. So that's not a joint we can replace, but we can fuse that joint, and that's always an option. So if you want to come see one of us, we're happy to help take a look. What is the recovery for non-replacement? Fantastic question. So if you don't do an ankle replacement, but you do an ankle fusion, that is a little bit longer of a recovery. And that's because we have to get those bones to weld and to heal together. So typically for an ankle fusion, you are not able to put any weight on that ankle for at least 6 weeks and sometimes longer. So if you have a lot of comorbidities like diabetes, obesity, there's certain things that we might want to protect your ankle longer for. So anywhere from 6 to 10 weeks or so of no weight on it in a splint or a cast. And then around 6 to 8 weeks, we can get you into a walking boot to start putting some weight on it, back into normal shoes around 10 to 12 weeks after surgery as well. But we get repeat x-rays to make sure that those bones are welding and fusing together. Can I get this surgery at an ambulatory surgery center, or do I have to go to the hospital for it? That's a fantastic question. Now, the majority of these surgeries that we talked about, ankle scopes, ankle ligament reconstruction, even ankle fusions and ankle replacements, can be performed in the surgery centers. And that there's usually cost considerations when it comes to that, and a benefit for the patient and insurance companies being able to do it at a surgery center. Just from a convenience standpoint, it's also really nice. Outpatient surgery allows you to come in, go home same day, and to recover in the comfort of your home. How much function do you get back with ankle replacement? Jogging, wearing regular shoes, boots, etc. Yeah, so after an ankle replacement, you definitely, our goal is to get you back into regular shoes. So sneakers, even smaller heels, boots, of course. And so normal shoes, not an issue. But when it comes to activity, that is something that is a little bit kind of surgeon dependent. We actually did a study surveying surgeons saying, hey, what do you let your patients do after an ankle replacement when it comes to activity level? And basically, the more you do from like a high impact weight bearing standpoint, the quicker you'll wear out the ankle replacement and that piece of plastic in there. So light aerobic activities, walking, even biking, yoga, golf, certainly all okay. Hiking, like light hiking and stuff. But getting into more of like running, jogging, high impact activities and sports like basketball with a lot of cutting typically should be avoided. Now I know like pickleball is really common these days. And so some lighter activities like that, like less intense pickleball is okay. But again, a little bit of that depends on your age and surgeon preference. I had a trimalleolar ankle fracture with an ankle dislocation 11 months ago. So for everyone else, that's basically this patient broke their ankle in 3 different places and dislocated at the same time. Scans were clean post-surgery, show no arthritis and inflammation. However, I'm still having pain and swelling daily. What would you recommend for the pain and inflammation? And so you are 11 months from surgery. So typically that once you get to a year, that's when you should see the most benefit in healing following the ankle. But as long as your surgeon has confirmed that the fractures are well healed and that there's no other complications, you unfortunately may have some early arthritis developing in the ankle. Now, even though we can't see evidence of that on imaging, early arthritis is just inflammation. So it's these inflammatory cells that can cause pain, and that's hard to see on imaging. So the pain and swelling, number one, compression socks. So I always recommend compression socks from the toes that go up to the knee, although I know we're getting into the heat of summer. But compression socks, if you put them on first thing in the morning before gravity starts working and you get that pooling and swelling in the ankle, it can be really helpful to control the swelling, which then subsequently is controlling your pain and your inflammation. Depending on your health, you might want to talk to your primary doctor about the possibility of going on an anti-inflammatory, a non-steroidal anti-inflammatory. There's over-the-counter options like Aleve and ibuprofen, but then also stronger prescription options. You may be able to consider a steroid injection into the ankle. And then finally, there are surgical options. So if you're really not getting better, an ankle scope to clean out some of that scar tissue that's developed in the ankle. I've had a couple patients with similar symptoms, either my own patients or other surgeons, and I'll scope the ankle after they've had surgery. And sometimes it's just a ball of scar tissue in there, and that can be hard to see on MRI or advanced imaging as well. So being able to clean out that scar tissue can be helpful, and even removing the hardware. Now, we also did a study looking at patients that had an ankle fracture, and for whatever reason, they had their hardware removed. And over 80% of patients were very satisfied and happy with the fact that they had their hardware removed. So that's always a consideration as well. What device do you use for replacement? So there's multiple different companies with great implants, new designs and new techniques. I actually had the fortune of training at a lot of really centers that are really high volume in ankle replacements, and every surgeon uses a different system. So I've trained on at least 8 different total ankle systems, which is pretty unique and something special about kind of my training and my background. And I don't want to kind of endorse any specific companies, but the device, again, is typically either made of cobalt chrome or titanium, and then you have a piece of plastic in between. Now, all of them have some kind of an on-growth surface that helps allow your bone and the metal to kind of adhere and fuse as one. And then there's different options for if there's really bad deformity or bone quality. There's some devices that just kind of coat the joint surfaces, and then there's other devices that actually have a stem that will go up into the canal of the bone and might be a little more stable. So a lot of us surgeons have a couple of different devices or companies that we work with. If you have ankle instability due to CMT, would a fusion help? It can, however, so for everyone else, CMT is Charcot-Marie tooth, and this is a disorder where there's muscle and ligament imbalance in the ankle. It's a neuromuscular disease, and it can cause a lot of deformity in the foot and ankle. These patients have really high arches in their feet, and that can cause ankle instability. Now, depending on how old you are, your age, and your symptoms, sometimes we actually start by correcting the deformity through the foot itself. And that's either with different soft tissue procedures like tendon transfers, releases, bony cuts to shift and realign the bones in your foot. And to realign the bones in your foot, that helps stabilize your ankle and put it in a better position. Oftentimes in that surgery, we also tighten those ligaments. Now, if you have really bad CMT and deformity, that can start to affect the ankle, and the ankle can become arthritic. And then there's different options like an ankle fusion that may be helpful. After having 2 ankle surgeries, one with tendon transfers with a dissolving screw and another with a titanium screw, what are possibilities of future arthritis in the foot and ankle? So you had 2 different ankle surgeries with tendon transfer and a dissolving screw and another with a titanium screw. Unfortunately, I'm not sure of what you had your ankle surgeries for, like what symptoms you were having before the exact surgery they performed. But what are the possibilities of future arthritis in the foot and ankle? That's a really hard question for me to answer without more information. But please come see us at any point. I am happy to help. Are cortisone injections recommended treatment, and how often should I get them? Yes. Now, steroid injections work fantastic in the ankle and other joints. What a steroid is an anti-inflammatory. It's one of the most powerful anti-inflammatories we have. So it can calm down a lot of that acute inflammation inside the ankle joint and can provide long-lasting relief if you're a younger patient and you just had a flare of really bad arthritis that we haven't been able to control with other conservative measures. But your joint is healthy and your cartilage is healthy, sometimes that steroid injection can just calm down that inflammation and solve your problem. Now, other times, patients that have more advanced end-stage arthritis, it'll just provide transient relief. And then in that setting, you can get injections spaced out every 3 months. We don't like to do it sooner than that. But every 3 months, you can get steroid injections if you do have like moderate to severe arthritis. And then one thing I didn't mention, but I get asked a lot, so I'll mention it here, are gel injections. So Synvisc or other gel injections are commonly performed in the knee. Now, unfortunately, in the ankle, they're not approved by insurance. So 99% of the time, we're unable to perform those gel injections in the ankle unless you pay for it yourself, which is incredibly costly. It's usually $5,000 to $8,000. So but most of our literature actually supports that steroid injections do just as well, if not better. And unfortunately, that's why insurance companies don't always like to pay for them. But steroid injections are a great option. Are some forms of exercise worse for arthritis, or as long as you're able to do the activity, is it okay to push yourself? Another great question. So We don't have any evidence that marathon runners have any higher incidence of arthritis in joints than other patients. So it's certainly okay to exercise if you have some arthritis. However, like higher impact activities like running, jumping, you may continue to kind of exacerbate or flare the arthritis and cause more pain. But I always tell people you're typically safe. If you're having a little discomfort, it's okay to push through. But if at any time you're having worsening pain and swelling that you can't get under control, then you really need a period of rest and to come see us. Can bunions be caused by ankle arthritis? Typically not. So it's probably, if you have a ankle arthritis and a bunion, it's probably unrelated, but sometimes bunions and flat foot deformity can go hand in hand together. So a lot of times patients that have bunions will have some ligament laxity, and that'll cause the bunion deformity, can cause a flat foot deformity. And the end stage, and this is getting a little off topic, but the end stage of a flat foot deformity actually starts affecting the ankle, and then you can develop ankle arthritis. So not necessarily bunions, but there are some other associations. Can prior ankle sprains be a factor in developing ankle arthritis? Yes, certainly. So every time you sprain your ankle, you risk damaging the cartilage inside the ankle. So the ankle joint is shaped like a dome. So every time you roll or you sprain that ankle, you risk dinging the cartilage inside the ankle. And over time, yes, you can have these osteochondral lesions, which were those kind of big pothole lesions develop. Patients that have recurrent ankle instability or sprains, about 30% will have those lesions. You'll start to develop scar tissue, bone spurs, and then the end stage of ankle instability. So frequent ankle sprains can cause ankle instability where you just continue rolling your ankle. And then over time, your body compensates by laying down a lot of scar tissue and bone spurs to stabilize the ankle. So then the end stage of that is ankle arthritis. And then it can cause deformity in the ankle as well. How can ankle arthritis be avoided or its onset slowed? So it depends on the type of arthritis. So osteoarthritis, which is less common in the ankle, but it's the most common arthritis in other joints. Osteoarthritis just is something that can happen with age. There's a really strong genetic component to it. And with that, there's honestly no great way to avoid it or prevent it, other than just making sure you're taking care of yourself, maintaining a healthy weight that puts a lot less stress on your joints. There's some good natural anti-inflammatories like turmeric and stuff that can help keep the inflammation in your body at bay. But unfortunately, there's no good way to really avoid or slow osteoarthritis. But then when it comes to post-traumatic arthritis, again, if you've had a bad ankle fracture, even in the best of hands, you had the best surgery, you had the best ankle fixation, some patients develop arthritis earlier than others. And we don't always understand why. So we're doing a lot of research in that. When you break your ankle or if you have a bad ankle sprain, your body releases all these inflammatory cells that are trying to heal, but they're actually really toxic to the cartilage. So those cells can start to eat away and damage the cartilage. And that is what we think starts to cause the post-traumatic ankle arthritis. If you have inflammatory arthritis like rheumatoid arthritis or gout, it's really important to follow closely with a rheumatologist or your primary care doctor. And you may need to be on medications to keep that inflammation at bay, and that'll help prevent progression of the arthritis. How can I get rid of swelling caused by ankle arthritis? So the RICE therapy, so resting it, and sometimes that's wearing a brace or a boot. Ice is a great anti-inflammatory. So when it comes to inflammation in a joint, like arthritis inflammation, ice is typically better than heat. So ice, compression socks are really helpful, especially if you put them on early in the morning before gravity starts working. Elevation helps minimize some of that swelling. And then some patients are on anti-inflammatories, whether they just use it for acute flares of swelling, or on a daily anti-inflammatory if it's deemed okay by your primary care doctor, that helps control the swelling. Are ankle replacements usually successful? Yes. So the literature now tells us that the 10-year survival is over 90 to 95%. So 90 to 95% of patients 10 years after surgery still have their ankle replacement, haven't required another surgery or new components to be put in, and are doing really well. Now, when ankle replacements first started 30 plus years ago, there was really rudimentary design, and those weren't doing as well. And so ankle replacements initially kind of got a little bit of a bad reputation, like, oh, they don't do as good as knees and hips. But over the course of the last 20, 30 years, we've continued to do research and refine different surgical techniques, different implant options. And now ankle replacements are an incredible surgery. My ankle hurts on and off. Many nights I wake up and it's aching. Why wouldn't it ache when I'm on it? Hurts on off. Many nights I wake up and it's aching. It could be just the position your ankle is positioned in at night. A lot of times our ankle is kind of in a plantar flex or downward position at nighttime, and your Achilles tendon, your plantar fascia, some of the other soft tissues in the ankle can get really tight. And so those first steps out of bed or in the middle of the night might cause some pain. If you're waking up with it in pain, why would it ache when I'm on it? Waking up with it in the middle of the night from pain could be due to other things other than arthritis, so it might certainly be worth getting an evaluation. With most arthritis, like osteoarthritis, patients will have some initial startup pain. So like first steps out of bed, that ankle joint is painful, or whatever joint's involved, knees, hips, it's all very common. You'll get this startup pain. And then it'll kind of ease up, you'll warm up that joint and it'll feel okay for a few hours. And then later in the day, the more active you are, it'll start hurting again. That's the typical presentation of arthritis. How many ankle replacements have you performed? Oh my gosh, hundreds in my training and in practice. Luckily, my training, the residency training I did at Duke is one of the highest volume total ankle replacement centers in the country. So is here at OrthoCarolina. My fellowship was very ankle replacement heavy. So again, I've been very fortunate in my training. I don't know an exact number, but yeah, definitely many hundreds of ankle replacements. So I've been very fortunate from that standpoint, and have trained on many different types of implants and designs. All right. Well, we are going to get things wrapped up right now, but I wanted to thank everyone so much for attending this evening. Hopefully I had time to answer the majority of your questions. As a reminder, this is recorded live, but then we also have it saved and it'll be posted to all of our social media platforms. So you're welcome to come back and listen anytime, or come see us in the office, and we're happy to help y'all. And thank you so much, and have a great evening.